there outside. You please start.
Yeah, not a problem. Not a problem. I can understand. Yeah, no
Thank
problem.
you so much.
Yeah, thank you. My video and audio is audible, right? See you, sir.
Yes, sir. Please go ahead.
Okay, good. Thank you. Yeah, myself, Dr. Saurav Shandilya. I'm in charge of academics and strategy at My Rehab Academy, the academy which you all are which all you have joined as a member since quite some time, and you are seeing like we are having a lot of free courses as well as the courses for upgradation of your expertise as well as the academics. Today we are here to learn about the ECG. Of course, ECG is one of the topic which is very well sought. I can tell like it's so common that every one of us know about ECG. I mean, however it is. So for normal, I just want to say that before we start ECG, I want to know from you. You can just type down in your chat box. How frequently do you see ECG of your patient? You can just type down in your chat box. I'll just see that. How frequently do you use ECG in your own patient? Or how frequently do you read ECG of your own patient? Suppose you meet a patient of a stroke. Do you really prefer to see ECG? In your chat box, you can type. Based on condition, very rare. Yeah, cool. So that is the problem. Actually, what happened, we have it is in the subject, but still we don't study in quite detail. And let me tell you, as a physio, when you are an important member, especially in this COVID, across the globe, people came to know, yes, physio is the important member for the cardiopulmonary unit, especially in the hospital and of course outside OPD. That's where they actually train the patient who actually come out of the. So yeah. To be truthful, sir, we watch the. Yeah, depends on condition. Yes, I can understand. I definitely understand. So most of the physical therapists, they don't see the ECG in quite detail. Of course, we are not supposed to see in the detail. But what I was thinking, since I was a good student in physics in my school as well as, of course, in plus two, and then ECG always well suited me in terms of even during my college days and later also. I just learned the ECG. Of course, when I see patient, I don't read very deeply that time, but I take uh, those things in my box, and then after that, I just go through that. So I just want to learn what is really the problem is. Okay, and I can tell you that once you know how to read, it's really very kind of, I can say you, it's one of the thing which actually you will love it. The thing is, like, most of us, we don't read ECG because we have forgotten many of the things, right? Many of the things like how ECG works, we know only that, yeah, PQRST, some graph is there, and then if you are very well connected with the cardiopulmonary unit, or maybe you are dealing a lot of cases of neurological rehabilitation, that time you come to know a lot of things about the ECG. But my dear friends, I am seeing that you guys are quite truthful and saying that, yeah, definitely, either rarely you see, or if you just see for just, okay, fine, I'm just seeing that. Anyway, we have a very bad, like a medicos mostly have very bad things to, like, we'll go for, directly impression. And we forget that it has to be clinically correlated. Okay, suppose a patient. Okay, suppose a patient. Okay, uh, let's talk about ECG. It's a kind of introduction part. What is ECG? Electrocardiograph, right? So what really ECG does? It actually measures the electrical activity of your heart, right? So how it is possible? How it is really possible? Okay, I'll just share. I'll try to share the screen. Just a sec. Just a sec. I'll try to share the screen. uh, my sincere request to every one of you that kindly sit with the pen and paper. Don't sit without pen and paper. Take a notebook. Today we are going to learn these things, of course, and then we have a lot of things we have to discuss in detail also. So, like I want you to do that pen and paper thing mostly because of uh, I want you to understand this concept very properly. Okay. Once you understand this concept, it is definitely that it's not the PowerPoint presentation mainly, my dear friend. I want to be very clear. So kindly bring your pen and paper and sit with me for another, I don't know, maybe about 2 hours. Because last time I was discussing with my two of the friends, close friends, about the ECG. And I can tell you that how time passed about 2.5 hours, and we were not even 60% of that. So of course, I will not take you too deep. I will give you the like overview. I will give you the how really do we understand about the ECG, and I will give you the introduction of certain other things also, I mean, related to clinical condition. And at last, I will tell you how you can spend some 10 or 15 minutes or maybe 20 minutes, and you can actually learn about ECG of a particular patient. If not 100%, my dear friend, you will be able to read at least 50%. So I want your complete concentration. I want you to sit with a paper and pen. And if you have any question, kindly chat, put it in chat box. Many a times I will not be able to see now. Probably I'll be able to see later. Yeah. So let us have a very good discussion about it. Uh, yes. So this is the class, detailed ECG for physical therapist. That's how it is. And outlined introduction, overview, and physios, how actually we understand the like the concept of ECG, and then principle, general idea, ECG strips. We'll have a look. Then we will have a deep dive into the waveforms, how waveforms really form. Okay, and what is the science and what is the biology behind it, what is the physics behind it, and then of course at last we'll see the normal, like we see that what is the normal ECG, and then we'll be seeing that what is the deviation. You can just see in the 10 to 15 minutes I have written. Of course, you need minimum 15 to 20 minutes. It all depends upon the practice. And then we'll go ahead now. Let us come to the, yeah. So let us come to this page where I want to write something. Yeah. So as everybody, you said that ECG, right? ECG is basically what? ECG is basically the electrocardiograph. It is printed on the paper most of the time, and then what happened here? You learn a lot of things about ECG, where let me tell you, nowadays it is not printed. Nowadays it is something which is actually gone, like the paper got hit, and then you come to know about like how you actually see what actually you see. That is something very, very important. And those important graph what you see, it is not actually the printed, it is actually the paper which get hit. So just a sec, I'll go with that. Just a sec, have patience. Yeah, see here, as everybody of you has told, like ECG is something which is the electrocardiograph. But why ECG coming on the paper in a different graphical representation, right? It's a kind of P wave, and then like you have a Qrs complex, then it goes like this, and then you have a T long prolonged rate, right? Whatever it is, we will discuss it later. But why it happens? First of all, try to understand your own heart. Okay, it's say for example, it is your heart. I have given just a schematic representation because all through the program I will not draw the proper anatomical heart, because the ECG is basically about the electrical system. So what happened here? You have SA node, right? You have AV node. We'll discuss again in detail this system. SA node, AV node, everything, then bundle of his, then left bundle branch, right bundle branch, and then Purkinje fibers. So what happened actually? You have electricity here, right? That get discharged to AV node, and then if it get discharged here, it actually come to the surface of body, right? So if you have a system, which measures the potential difference, got my point? Potential difference of both between the, say for example, positive and negative, if you are able to gauge the difference, that particular millivolt you can actually draw on the paper. That is what we say ECG. Okay, that is nothing very different about it. Okay, now say for example, let us put it in a very, what we say, scientific way. As the cardiac impulses passes down through the heart, electrical currents are spread into the tissues of the body, right? That's what I told you. So of course, first of all, it will definitely, it started with the SA node, then across the heart it will spread. How it will spread, we will come later, but it will spread across the heart first, then it will go to the lung, and surprisingly, lung is a very good conductor, right? So what happened here? Across the lung, and after that it comes to your surface of the body. That is how you measure the positive and negative and the potential difference. That is what you print in a graphical format, that is called the ECG. Okay, well, this was the one point. Okay, now so let us see the what is normal ECG, then probably we'll have some more discussion about it. Yeah, see, this is the normal ECG. I think we have somebody to talk about it. Well, so this is the normal ECG. I will come back again to this later. First, try to understand normal ECG. I know every one of you know about it, but still, it's my job to go revise, then again go to the detail. See, this is the P wave. Okay, P wave is nothing. It is a atrial depolarization, right? Then you have a Qrs complex. That is what? Ventricular depolarization, right? Then you have a T wave. That is what? It is again the ventricular repolarization. Simple, right? My dear friend, if you are able to find atrial depolarization, ventricular depolarization, and ventricular repolarization, then where is atrial repolarization? Where? Can you see that? Atrial repolarization anywhere. I said this P wave is for atrial depolarization. QRS complex come for ventricular depolarization. Then you have a, like a ST segment, and then you have a T wave, which is coming for the ventricular repolarization. But we have left somewhere atrial repolarization. Can anybody type in the chat box what happens to atrial repolarization? Why are not we able to see that? Anybody? No worries. Why are not we able to see that? Anybody? I'm waiting for your chat. Otherwise, anyway, I'll tell you, but I'll give you just 1 minute time, because once you are interested in learning this, I'm sure on your pen and paper you'll be drawing this, and you know this graph really. Okay, because of conduction proceed to AV node due to overlapping phase. Yeah, come to the more clean. I want you to be more clean. It happens along with the ventricular depolarization. Yeah, okay. Then short duration. No, not like that. Yeah, fine. Somebody told it happens along with it coincides with ventricular repolarization. No. It actually coincides with the ventricular depolarization. Whoever has written that, kindly correct it. Okay, low amplitude. That's really correct. Low amplitude. It has low amplitude, no doubt. Yeah, it merged with the ventricular repolarization. No, again correct it. It actually coincide with the ventricular depolarization. So that's the reason we don't even find this atrial repolarization. right? So now just see that relationship of atrial and ventricular contraction of ECG waves, how it goes. Before contraction to happen, let me tell you, depolarization has to spread across the muscle to initiate the atrial contraction, right? So what happened? P wave occurs just before the atrial contraction. That's what you are seeing, the P wave, right? Then it causes the atrial contraction, what you say atrial depolarization. And then QRS wave, of course, occurs just before the contraction. That's what it causes the ventricular depolarization. And then after that, you have ventricles remain contracted for just few more seconds, few more milliseconds after the repolarization occurs. Okay, that is what you find the T wave, because it is a ventricular repolarization. Now, okay, ventricular muscles, like it start repolarization in some of the areas the much before the complete depolarization stops. If you remember, I'll just choose the different color, maybe that will be more helpful for you. Yeah, let us choose this. See what I said you, if you remember, uh, if you remember, like ventricular wall, the ventricular wall is something, ventricular wall is something the thicker than atrial wall, in fact much thicker than atrial wall. And then every one of you know about, if it is a ventricle, then it is a left ventricle which actually is more thicker than the right ventricle, right? So in this case, what happens? What happens to atrial repolarization? Atrial repolarization get masked with the ventricular depolarization. Okay, so we don't see atrial repolarization in many of the normal ECG, but story is not finished yet. Okay, story is not finished yet. Story is atrial repolarization. In fact, atrial repolarization, as I told you, is in fact more commonly seen, or whichever the condition it is seen, but it is also seen some of the places, what you say atrial repolarization. That graph has been found out in some of the condition, and I can tell you this is the graph which is not correct. So it is a pathological feature rather than any physiological feature, right? So that's what I want to learn you about it. Atrial repolarization happens, my friend, but it doesn't happen uh, according to the ECG paper, normal ECG paper, but it happens, right? If you don't have a good QRS wave, then definitely you will find it. Well, okay, fine. This was the one theory I wanted to let you understand about it, atrial repolarization. Then any other things also, which is the common overview I want to give you. Say, for example, I want to tell you like uh, uh, something that atria repolarizes, like approximately, if you talk about the duration, then it is about 0.152, almost to 0.2 second, immediately after the P wave. That happens anyway. However, this occurs just at the moment of the QRS complex. So getting recorded in ECG is how? Totally obscured by, as I told you, QRS wave, but atrial T wave is rarely observed in ECG, as I told you, but it is observed, right? So in some of the condition. So these kind of things recorded by the pen recorder earlier, or the pen or the paper, which is a kind of graph paper. And I can tell you those graph paper are a bit different. We will discuss about the graph paper just now. Immediately after this slide, we'll discuss about the graph paper, because once you understand the graph, you will have a clear-cut concept about basically about how the millivolt and millisecond measured. So what I wanted to tell you, PQRST, everybody knows, every one of you knows, but try to understand the timing. Okay, the timing and voltage is equally important. So let us talk about something about the graph. I think I have a graph paper also here. I have injected. Look, this graph I have brought for you is little bigger graph. Okay, it's little bigger graph. So this graph, you can see you have small size boxes, right? A small square, SS will denote like SS, a small square. Okay, so if you see the bigger graph, you have 1, 2, 3, then of course 4, and then 5. So you have a 5 small square. Okay, and on the paper, ECG paper, which is the basically the 6 kind of what we say 6-second paper, nowadays mostly it's used one, and then the y-axis is basically the millivolt, the current, and this axis, x-axis, is basically the time. Okay, so here what happened, look at here very clearly, one small boxes represent for 0.04 second. Okay, so full this 5 small boxes, that means the one big box, I want to say you like this, one big box, this will be representing the 0.2 second. How it happened? Because 0.04 second, which was the small size, like a small box timing size, has been multiplied by 5. If you do that, it comes 0.2 second, right? So understand the clues of graph. That's what I told you. Okay, this particular thing, if you understand on 6-second ECG paper, let me tell you, it will be a lot of benefit to you to understand, to like the timing as well as the how paper passes. So most of the time, one more thing I'll let you know here, most of the time it is a 25 millimeter per second. If you see one normal ECG paper, you will find the speed of 25 millimeter per second. I think you would have seen that. At last they'll be writing the paper has moved on speed of 25 millimeter per second. I'm talking about Indian hospitals where actually I have worked. I think I have seen most of the modern ECG going with the 25 millimeter per second. Well, so as I told you earlier, it was recorded by the pen, but now it is the paper which get hits up, particular timing, it gets hits up, like it gets hit up, and you know what happened here? Here you find that you find the graph here. Okay, P wave, then it goes down, then QRS, then it goes prolong, and then T wave. Okay, that is how it happened, because it hits. Earlier it was a pen recorder, now it hits and the paper comes according to the heating. Okay, that is the technical part. We'll not get into much detail of that. What is important for us, we'll go for that. Okay, now you understood that. Now my dear friend, you have to understand something called the isoelectric. Okay, what is isoelectric? Isoelectric line is the kind of baseline. If you see in the ECG, let me go to the base, let me go to this graph. You can see here, you can actually see the kind of what we say that yeah, this is the isoelectric line, isoelectric line. This is isoelectric line, because there, the midline, the baseline, where actually the all graph comes and states, like positive and negative. How it happened, the positive and negative, that's a different discussion. We'll do a little later, but something like this, I think you should understand that, because positive deflection happens, then it happens the negative deflection also, and then of course this is something, the midline, what it actually the all graph goes like that. That is called the isoelectric line. Okay, so isoelectric line is utmost important to understand, so I will just mark with the highlighter once again, so that you will have a better idea where is the isoelectric line. Maybe who has joined little late can see, this is the isoelectric line. Is it clear with everybody? You can say by chat box yes or no. Okay, this is called the isoelectric line. Okay, so now you will have no issues to understand about the isoelectric line. Well, so why isoelectric line? I am giving you more stress, because once we will learn about the different type of graphical representation, that time you will understand why isoelectric line is important and why it is going for the positive, why it is going for the negative. Well, so till here we have discussed about the overview of the ECG. After that, yeah, yes. So, like I have brought some of the revision pages also for you. So, like I have written very clearly, ask me if you don't get it. So, of course, you will be able to ask through the chat box, but I may not see your chat most of the time. But keep the question with you. I will be able to take your question probably at last. If you don't, or in between, I'll give you some time. So till here we have come. You have any question, please ask me about the overview of ECG. I know, okay, depolarization and repolarization. Somebody asked, okay, I don't know your name, sorry, but somebody asked depolarization and repolarization. Of course, I will. Okay, well, okay, depolarization and repolarization. I'm sure every one of you understand that concept of, say, for example, here. Okay. Okay, well, so okay, just a minute, be on be connect, I mean, just remain connected. I will try to share some different paper if it is possible. Just a sec. Just a minute, I'm trying to share that paper so that we'll have a better discussion. Yeah, here onward we will be more on this. Is everybody able to view this? I have shared a blank page. See you, sir, is it visible? Okay, well, I think there is some problem, cannot be shared that. We'll talk about this only. Okay, somebody asked about the depolarization and repolarization. Let me tell you, since earlier time you would have knowing about the depolarization of the tissues happen mostly because of action potential, right? It's something called the action potential depolarization happens, right? So what happened basically, it get depolarized. How? Say for example, if it is like this, action potential comes. I'm sure everybody, all of you know about all or non-law, where actually the action potential comes, which increases the, like entry of sodium ion, and then after that everything get depolarized. That is how the action potential get built up and method of excitation happens, right? It tissues get excited. Well, so that is what today I will not talk about more of depolarization, sorry, but every one of you know about depolarization. So let me check it. And then what happened here, once the action potential stops working or the action is done, then it start, the sodium goes out and the tissue get repolarized, right? Right, repolarize, it get. So there is a polarization, there is a natural polarization, natural, I can say the resting potential for every, yeah, this is the best word to at least to make understand in early part. Resting potential is there with every cell. So if you can excite it, that is how the depolarization happens, right? The story is all about depolarization, right? So once you have a depolarization, then probably you are able to understand that. Once depolarization, then the tissues get repolarized, means after the action potential finish its work, then again every tissues get repolarized. That happens everywhere, you know very well. I will not get into the muscle action potential because you know the cardiac is a very big chapter. When we talk about that, we talk about not just only the skeletal. I mean, we have to talk about the smooth muscle. That will be talking about our classroom courses sometimes later. So depolarization, repolarization, I made you understand in a very simple method, very simple method. So that is how. Okay, well, yeah, isoelectric line, resting state of cardiac cells. Yeah, well, why atrial repolarization is not seen in normal ECG? I actually explained that atrial repolarization is not seen in normal ECG mainly because it happens, but the effect get masked. The graph, which you know, like the graph is here. If you see, the graph get masked by QRS complex, you know, P wave, and then you have a down Q, and then RS, and then T wave. So generally this QRS complex, it actually mask it. Okay, why? Try to understand. Try to understand. Here what happened, I'll separately do it. Okay, let us talk about this in a very simple manner. Okay, this is the apex of the heart. Okay, apex. This is the left ventricle, of course. This is the right ventricular wall. Sorry, wall. Left ventricular wall. This is the right ventricular wall. Sorry, I'm extremely sorry. Left ventricle is more thicker. I'm just making understand. Somebody asked me why it is not seen. So what happens? See, compared to atrium, where the superior and inferior vena cava comes, the blood comes, every story you know about it. So what happened compared to atrium, the size of the wall, as well as the, I can say you the volume, it is too less compared to the ventricles, right? So you have a long time depolarization moving in the ventricles compared to the atria. Number one. Number two, since you have a more thicker wall also, so in ventricle itself, the tissues, suppose this is, I'm coming on that topic little later, but try to understand the tissues which was depolarized earlier start getting repolarized, but still at last ventricles are still getting depolarized. That is the main reason. That is the main reason you don't get to see atrial repolarization. Okay, in normal ECG. Well, so so I will come now. Probably let us erase it, and then I'll come to the new topic again. How it is important to us. Okay, so we have discussed a lot about overview of ECG. You came to know why atrial repolarization is not seen. Those who have not understood, again, can note down the question. We'll talk again it later. Probably by that time they'll have enough concept to understand, and that time they may not ask also. So now let us see. Okay, I'll talk about the normal voltage. Okay, normal voltage. Suppose I'm just talking about the normal voltage, but don't think that we are using that voltage. But still, if you go to the cardiac surface directly, it is about 110 millivolt. But the story is different. Say, for example, a person is here. Okay, a person is here. Here is his cardiac. Okay, cardiac muscle. If you put directly electrode on this, it may be 110 millivolt. But the moment it comes on the, you know, like a neighboring tissues and come to the surface of body, it will go to the 0.2 to 0.3 millivolt. Sorry, 3 to 4 millivolt. But again, 3 to 4 millivolt. But again, what happened here in atria and ventricle? It will go to the 0.3 to 0.4 millivolt. Why it happens? You'll come to understand now. Okay, so normal voltage of ECG, what I told you, it depends upon the manner how you apply the ECG leads. It actually depends on that. But anyway, how you I mean, how many types of leads are there? I'm sure you are confused about it because you see lot number of leads, and then when you see the ECG paper, you feel, oh my God, so zigzag. So you just see the impression. Okay, anything is there? Right bundle branch block. It looks like this, or clinical, like correlation, you do it, or something like that. So, okay, so somebody asked about the recovery phase. Yes, it is like that. Okay, so what happened here? It is totally dependent upon how you apply the ECG leads. Leads we will come little later, but before that you have to understand how the graph and your I can say that how your graph as well as your cardiac get correlate with every graph. I think that will clear more and more and more. Those who have not understood the depolarization and repolarization can take 2 minutes gap, no problem, can understand with their basic books. But normally the depolarization is something we say that we have depolarized, means polarization is already there. We have depolarized with action potential. That tissue has got excited. Okay, it got excited. That is what it is meant for, to work. Simple, very simple. And the moment the work is finished, recovery phase, and then after that, what you say, it get repolarized. Okay, so depolarization, it is excitation. It brings excitation, in fact, and then muscle contraction happens, and then repolarization again back to resting level. Is it clear? You can just send me yes or no. If it is no, then again we'll be talking about after a few times, after a few minutes. No, thank you. Thank you so much. So now, as I told you that it definitely depends upon the how you apply. So now the next theory is flow of current during the ECG. It is very important to understand. Once you understand that, most of your I can say the doubt get clear. Okay, how the flow of current across the chest happens normally. Okay, then we'll be talking about the conduction system, how it happens. That's a different thing. But flow of current in the ECG, how it happens, it should be like how it happens, that's anyway we are going to discuss. But how it is getting recorded. Okay, what happened here when you are with the ECG. Say for example, I'll tell you one very simple thing. Say for example, I'm showing you one cardiac muscle. Okay, very simple. And then a simple cardiac muscle I'm just showing you just for a schematic. Don't think that it is a real one, just for a schematic diagram. Okay, it is positive, outside, it is positive, and then it is inside the negative. Okay, normal polarization method. Well, okay, I'm talking about cardiac muscle. There are a lot of things to understand about cardiac muscles. I don't want to get excitation of cardiac muscles because cardiac muscles, it's not just it needs the sodium potassium, it needs actually the calcium channel blocking also, right? Calcium channel transportation is also needed. So sometimes later we will be discussing about, not today, maybe sometimes later, what is the difference between the skeletal muscle and the smooth muscles as well as the cardiac muscles, because cardiac muscle is one of the specific kind of smooth muscle, right? Here the, like, unlike the, I can say the skeletal muscle, where actually the uh, pyruvate dehydrogenase, right, actually it works and brings the like what we say that sorry, lactate dehydrogenase, it works in such a way that lactic acid brings, right? So it's a story of PDH and LDH we'll be discussing later. That's just for your information, that pyruvate dehydrogenase to lactate dehydrogenase, that's how you have a lactic acid more into the skeletal muscle, especially after the anaerobic respiration, and then you get tired, after some exercise. You have aerobic phase, then you have an anaerobic phase, and then lactic acid get deposited, that's how you get tired, right? But suppose it happens in cardiac, then no chance of life, right? So here our ultimate architect God has done in such a way. Here your lactate dehydrogenase, I mean the lactic acid, it works in such a way, the PDH, the pyruvate dehydrogenase works in such a way all the time, it makes to pyruvic acid, right? It doesn't let lactic acid to get deposited because it will bring the muscles to stop working, and it can fatigue the muscle in general, I can tell you, right? So that is how it is a difference. But right now it's a cardiac muscle. Just try to understand that you have a normal polarization. How do you record it? Suppose you have a wire from here. Let me choose some different color. Maybe it will be better for you to understand that color. say for example, blue. Yeah, let us talk about blue, maybe. Yeah, cool. So you are having a wire here, you are having a wire here. Okay, now you are connecting it. If you don't understand, no problem. This is just for normal physics. Later I can make you understand this. Okay, so once you record it, it is toward the negative. Okay, because in general there was a negativity inside, but once I'm talking about surface of cardiac muscle, it is like this. Okay, once action potential happens, or action potential starts what we say depolarizing your cardiac muscle. So what happened here, if you take that time the recording will come like this. You see, recording will be at 0. Okay, but at last when the action potential has already worked, that time recording will go for positive, means depolarization has completely done. Okay, that time if you record. So why it happens like this differently? Because earlier it was like this. Okay, naturally what happened, after some time when the action potential starts setting in, that time in terms of setting in, this changes happens. Okay, sodium, potassium, so all these ionic exchange, it is almost equal at both level, outside, inside. That is the reason the potential is 0. But when it is a depolarized one, it is a potential, it gets positive. Why? Because it has got depolarized. I have written plus here in general, but generally it is a depolarized one, right? So this is how you have to understand the concept of how do they record it. Okay, now that is the one concept of recording that was not very, very important, but what is coming is very, very important. Why do you see many of the, and for this you should have a little bit of physics knowledge too. Okay, why do you see on ECG many things are like what we say, uh, just a sec, I'll erase it. And then why do you see many of the graph is ulta on ECG? I mean the opposite on ECG. Anybody has any idea can type in the chat box. Why do you see, say for example, you find the Q wave down? Why it is like this? Or maybe I'm talking about physiological, maybe, but what about the pathological thing when you find a lot of graphs down? Or maybe some of the leads. When I'll be discussing about the lead, I'll tell you. But I want to know from you why you find anything which is below the isoelectric line. Why it is like that? Anyway, it was a potential, right? It was a potential. Potential is always positive. It will never go into the negative. But why it is showing the negative deflection? Anybody has any idea can share in your chat box. I will just go through that. Don't worry, if it is wrong I will correct. Even though if I'm wrong, please correct me, that's not a problem. Okay, here with authority of a teacher, I am here, but still if I make some mistake, you have every right to correct me. Okay, yeah, yeah, fine. Somebody asked about lower limb leads, wrong placement of leads due to action potential. Pradeep Kumar Yadav, you are completely right. It's because of action potential, but I just want to know from you this action potential, why it is recorded in negative. Once you tell me this, then it will be very easy for you guys to understand the placements. Wrong ECG leads placement. No, 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 not like that. Because of increased ionic concentration due to pathology. Yes, yes, yes. Action potential, yes. Placement of electrode. But those who are writing action potential, I'm happy. But why this action potential? When there is a, say for example, 70 millivolt was that, and 90 millivolt you want excitation. 90 millivolt would have had come. But why this time you have a graph which is going down? Say for example, in AVR, everything is down, right? Sorry, AVL, or maybe the lead one, everything is, you find the QRS completely down. Those who have an idea about that, I'm not saying for everybody, but why deviation from the normal axis? Somebody iPhone, sorry, I don't know your name. Action potential, yes, I agree, action potential, but hyperpolarization, no, it doesn't happen. Hyperpolarization, that is a pathological part. Depolarized, yes, I agree, that is a myocardial infarction. No, 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 not like that. I'm saying that in normal ECG also we have a graph which is going down from the isoelectric line. It is going down. Why? Going away from SA node. You are closing the reality. Yes. Anybody else? Okay, fine. Let me explain then. So I asked many a times, if you find the ECG, you find there is a oh, sorry, completely sorry about it. Okay, well, now you have a line like this, right? You find many a times, okay, this is the normal P wave and then little Q wave, then Qrs complex, what you say, S wave, and then you have a T wave, right? So I have a question, and it is very genuine question, that why you have this part down from the isoelectric line. Okay, it is nothing, it is simply a vectorial representation. If you have any question, I'll answer you everything, but right now you just try to understand what is vectorial representation here. Okay, somebody told me the potential travels from SA node to AV node. I mean, I think Dr. Upasana or somebody, yeah. So what happened in that case? In general, I'm telling you, say for example, this is your cardiac. Sorry. Don't consider it is a normal picture. It is just for a schematic diagram. Okay. Here you have a negative. Here you have a positive. In general, I'm asking you. Okay. In general. Okay. Let me explain you a little more clearly so that maybe it will be very easy for you to understand that. Okay. Well, just a sec. Here. Okay. Okay. I'm simply saying that suppose here, okay, do one thing, you will understand this better just after this graph, but let me tell you. Here, suppose somebody told SA node, very clearly they told, I mean, I agree, SA node having this part, the electrical impulses get discharged in every direction, isn't it? Well, now, suppose simple thing, okay, same way it will come to AV node and all those things. Suppose one impulse come to this side, okay, and the wall is thicker. Well, one impulse goes to this side, definitely wall is thin. Okay, do you think the both will be simple, I mean both will be one type? No, right? Why? Because one goes like this, one goes like this, one goes like this, one goes like, there are various vectors which is creating the pressure. And I can tell you this is electrical pulse, and I don't know how much you remember about the physics, but it's a vector and scalar thing. Vector is a quantity which has a direction and magnitude both, and scalar is the quantity which doesn't have a direction, it's only have a magnitude. So according to physics, if you remember, like displacement, the direction, okay, these all are the kind of vector quantity. But when you come to the scalar quantity like weight, you don't have a direction, but you have a magnitude, right? So here I mean, electrical current is a different thing. Current is again not complete vector, but still let us talk about the vector. It has a direction. Do you think everywhere it will work? How can your graph can show it? So what happened? You have a resultant vector. Have you heard of resultant vector? If you remember your physics, okay, you will have a resultant vector. Okay. Okay. So it was very simple. Suppose one vector going like this, one vector coming like this, one vector coming like this, and in different direction. Of course, don't talk about magnitude because you'll get stuck here. One is going like this everywhere. Now we will have something which is the which will have the what we say the resultant vector. Now, why it is so important to tell you this? I'll tell you. What happened here? Say, for example, you have kept V1, V2, V3. I'll come to that anyway, but try to understand. Suppose here it was a V4, V5, and V6. Well, now these electrodes will not measure exactly the same from for current coming to this. It will have a different way. How? Now you can see this. You can see this. Okay. So suppose you have a more current passing this side, and suppose you have a less current passing this side. Okay. Got it? What will happen? The resultant vector will definitely go toward this, where there is a more number of currents passing, or you can say more magnitude is there, right? So that is how it will get deviated. So this is a concept of deviation. I'll come to this later. Okay, deviation is a very big concept. Resultant vector is equally important. So now from here onward, before talking about the lead, we will talk about the conduction of heart. Okay, anybody want any break can tell me, because here on topics will be more much more serious, even more serious from now. Okay, those who wants to go for the break can go for 2 minutes and come back. I'll be starting the conducting system of the heart, what you know already, but still we need a lot of things to revise it today, because without learning the conducting system once again, or without revising it, you are not able to understand what is ECG completely. So today, yeah, let us start it. We'll not wait enough. So we will be talking about the conducting system, no doubt, but conducting system, I just want to know from you guys, conducting system of heart, every one of us has studied. Do you know the conducting system of heart has been in correlation with ECG in such a way that without this, we cannot do anything. Okay, so let us draw a very simple diagram of heart so that you know it will be more clear about it. I'm going a bit slow because I don't want to rush it, or probably you may have some other commitment later. Sorry. Okay. Now, basically, you have what? You have here four chambers, right? Four chambers, basically. I'm a schematic diagram I'm doing so that you can understand better. You have a four chambers, basically. Okay. And chambers, what you know very well, right atrium. Sorry, I will write it with the pen only. It may not give you a good impression. Right atrium, then left atrium, then you have a right ventricle, and then left ventricle. Now what happened here? Okay, you have a sinoatrial node, right? Sinoatrial node. I'm talking about the normal conduction system of the heart. After that, we'll go through the different waves and how the waves get correlated, and it's very interesting topic to go ahead. Okay, so this is SA node. What happened from here? This impulse goes where? AV node. Every one of you must know this, right? From AV node, it goes to what? Anybody has any idea? Bundle of His, right? After that, it goes what? It divided into two, left bundle branch and right bundle branch. So today is a very good day to revise it also, right? I am not sure how many of you are a student, but still it's good for you to get revised. Yeah. Then after that, of course, it's a Purkinje fiber. Okay. Purkinje fibers. So this is how the conducting system of the heart. I have not drawn a complete anatomic heart. Okay. I have gone to the schematic diagram where I have shown the SA node. Then it has gone to the AV node. Then it has come to the bundle of His. Then it is a right bundle branch, then left bundle branch, and then of course it is it goes to the ventricular wall with the Purkinje fibers. And Purkinje fibers will be the something which is the ending point for the impulse to bring out the depolarization. So I'm sure that every one of you have got it, and I'm not sure if there is anything. Yeah, as a note, yeah, I think I'm right. Yeah, bundle of His, and then it get divided. Now, My dear friend, there is something called inherent, okay, inherent heart rate. Do you have any idea about this inherent heart rate? Anybody can tell me. Okay, very good. I really liked it. Invariant heart rate. What is that? In your chat box, you can type, what is that? Okay, okay, I'll only tell. As a note, if it is discharging the impulse, the heart rate will be generally 60 to 100 beats per minute, right? In general, I'm giving you complete explanation. I will not, it may be a complication. No, 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 it is not a complication. It's just a simple thing. I'm just telling you. Okay. Suppose you don't have anything from SA node, or it doesn't get properly coming, and AV node it comes. Do you know there is a always delay in AV node? AV node is a very slow conductor. Okay, compared to SA node where it actually starts, AV node is a very slow conductor. So surprisingly, what happened here, AV node, it can also beat 40 to 60 per minute. Okay, then you, or maybe even the bundle of his, same, okay, slow conductor compared to as a node. Then you have a left bundle branch and right bundle branch that can go to the 20 to 40 per minute, including Purkinje fibers. That is how the beating capacity I have told as an inherent heart rate. Yeah, Dr. Upasana Puri, you are completely right. When AV become conductor and when SA has issues, really wonderful. I'm very happy to have people who have joined today like you. Now, if you have that concept in the mind and you see the X-ray, I'm sure you'll be able to find that PR wave elongated. Why? Very simple. SA node is not working so much, right? So what will happen? The elongation will go away. I mean, it will come more, right? Right. So, and then of course, there will be a lot of changes to P wave also. I will not talk about that much. So after having the concept of this bundle of, I mean, sorry, the conducting system of the heart, let us talk about, again, go back to our basics and talk about the uh, how every wave forms work with ECC. Okay, I think this will be very interesting. So this is a normal isoelectric line, and here I think I will choose probably the right color. Okay, so here we have, of course, the P wave, and then we have a little Q, RS, and then again the T wave. Okay, now let us choose about the P wave and see the story how it goes. Okay. Yeah. So in P wave, I will draw again the heart of the same my choice, uh, because I want you to see what exactly happens in the heart. Okay. I want you to believe me. Lead 2. We'll be talking about the lead 2 right now. And I want you to trust about it. Okay. Yeah. Sorry. If you want to do the drawing in your paper with you, you can. I have no issues. Well, we'll divide the heart into 4 chambers. Okay, so this is what I was talking. Right now, I'm talking about P wave correlation. Correlation, you say, or how the physiology or how the mechanism of P wave occurs. Okay, I'm talking about that. I'm not talking about anything else. So I'll be drawing it. I have drawn a simple heart. I want you to trust me for lead 2, and this is a negative. This is positive, just for understanding. Okay, and you know very well Okay, fine. Axis part I'll talk later. There is something called left axis deviation, there is something called right axis deviation, and then heart itself is not a straight thing. It is a 59-degree, tilted, and apex, of course, it's down, and the base of the heart is up, as every one of you know. Okay. Well, so here, what I was saying, I'm correlating with the P wave. So I will draw the P wave first. Okay. Yeah. So what happened actually here? P wave. You have here as a node. Okay. It discharges and it goes to AV node, right? But at the same time, my friends, the discharge happens, as I told you earlier, discharge happens with, sorry, yeah, discharge happens to every direction, isn't it? Right? Try to understand. As deeply you can understand, please try to understand. Okay, if you ask me 100 times, I will tell you. But when I'm teaching, I want people to understand everything. So the current goes to every direction. It doesn't look current will go only this direction, right? When it is discharged, an atrium, like throughout the atrium, the thing is like it has what we say that it happens. The current goes down. So what happens basically? It gets discharged to local tissues everywhere, right? So you have current like this, like this, like this. So you have a resultant vector. You have. I will just select again the black. So okay, you have a resultant vector here, which is coming to the AV node. As I told you earlier, if it is any recording from negative electrode to positive electrode, or if I have not told you, just let me tell you, you know very well, negative charges to positive charges, if it goes, there is a flow, right? There is a flow which has to be indicated in the positive, means there is something called the current flow has happened, right? So what happened here, resultant vector is toward the AV, okay, and that is the reason atrial polarization get recorded like this, P wave. I'm sure you understood that, right? Because SA node to AV node, it has come, but how? Does it come directly? No, current has gone everywhere. So it has contracted the atrium. And now resultant vector, which is very strong, and you can see there is already negative electrode here. There is a positive electrode here. From negative to positive, it has happened. So it is a positive deflection. So on the graph paper, you find P wave being the positive deflection. Is there any question you have? Please ask me. Any one of you. Okay, I think you all understood this, right? Okay, well, so the current flows from negative to positive, and then you have a P wave recorded positive. The reason behind, you have, I told you, please trust me sometime, for some time, that I'm talking about the lead 2, where actually you have a negative up and positive down, if it is the condition. Suppose if it is not the condition, then what will happen? Positive deflection causes only, I'm telling you. If you see here what I was saying you, negative to positive, if the current flow is there from negative to positive, the recording will be coming to the deflection positive. Why? Because it has gone, current has shown the positive deflection. But suppose current is flowing, of course current is flowing from negative to positive, but your recording is here positive terminal, it is the negative terminal. Okay, recording terminal, I'm telling you, then it will show the negative. So in some of the leads you find the P wave also going ulta, right? Isn't it true? Right? So that is the thing. Recording terminal I'm talking about, friends. Recording terminal. How are you recording? Negative up, positive down. And then you are seeing the resultant vector going from the negative to positive. If you don't understand this, no problem, because ECG machine is doing everything for you. You have to just read the ECG. But I want you to understand why it happens. It is all because of the resultant vector. You have any question on this? Please ask. No question? I thought that we'll have some questions. You have. Okay. Well, let me check. Clear. Okay. Please repeat. Okay, fine. I was telling. Yes, Q and S, I'm coming. Why it is a negative deflection? I'm coming on the Q and S. And then repeating part, I'll tell you again, recording terminal of that. Okay, why are you jumping to the pathological conclusion, Baba? Just wait for some time. What I'm saying you, P wave is purely for depolarization, Dr. Samila, because polarization and depolarization, don't get confused. Depolarization, something that it has depolarized means the action potential has set in and contraction has happened. So just before contraction, you need to depolarize something, then only it can happen. Again, if you repolarize, it will be a normal thing, right? Yeah, I'm coming for explanation again. What I'm saying you have, suppose I told you, just think it, you have one lead here which is having a negative terminal here. Okay, negative terminal here, recording terminal. Here you have a positive terminal. If your current is flowing from negative to positive, that means it shows on record the positive deflection. Simple. And if you have a recording terminal ulta, I mean the opposite one, recording terminal, in that case you have a positive up and negative down, still your things will be recorded, but it will record it going down. It will not record it going up. It will get recording down. Why? Because negative to, I mean, of course, the current always flow like this. But if you just try to, like measure from the opposite side, what will happen? Graph paper, it will go opposite. It will show definitely down, but it has, even though it has a down from the isoelectric line, but it has certain contraction value. It has reached to the proper level, right? Action potential has definitely set in, but it is recording wise, it all ECG is all about recording. Okay, which lead, how are you recording? Thank you for understanding. If you have understood that, now after P wave, we will not jump to the QRS. Just wait for some time. We will be jumping to the next very important uh, feature. Here only we'll decide. Sorry, here only we'll write it down. PR interval. You would have heard PR interval. What is this PR interval? You know very well PR interval, but how you have to apply for your normal patient? You see PR interval elongated, PR interval shortened. You don't know what is the PR interval, how to correlate clinically. Why do we need this kind of capsule knowledge? We need this sort of knowledge to understand better our own medical science. Okay, it's definitely a different thing that we have a lot of things to do with that, but still you will have in your picture how you have to do it. So next part is, okay, fine. I'm sure I can go straight away next rather than waiting. Next part is PR interval. Okay, PR interval, very, very important. If you remember, okay, if you remember, I told you in the heart, okay, SA to AV node. Okay, PR interval is what? It is a distance. If you go to the proper that particular slide, you can find it is a distance between the interval between the P wave and the starting of the QRS complex. So here what happened? What is that? Why PR interval comes? I'll tell you. Because as I told you earlier, AV node is a slow conductor. Okay. If something is a slow conductor, after the PR wave get repolarized, what will happen? It will continue on the straight isometric line before sitting on the QRS complex. So this is why it is happening, PR interval, because it is a slow conductor. Okay, even though the depolarization is sorry, the repolarization is finished. This is the repolarization. The atria is getting setting in. Okay, it is finished. Before starting the depolarization for ventricles, it actually there is a delay, right? There is a delay because it's a slow conductor. That is how no potential is generated for some time, for some time, right? If it is a no potential generated, what will happen? Your reader, it will continue on that isometric line. That is about 0.1 to 0.2 seconds. That is the PR interval. Okay, this is the PR interval. So if your before depolarization, still your repolarization is finished, but still no potential has set in. So what will happen? It will continue like this, right? That is how the PR interval happens, 0.12 to 0.2 seconds. Is it okay? Is it clear? Fine. And if you see, like normally on the graph paper, that will be 3 to 5 small boxes. We'll come to that later. Still a lot of time for that. Okay. So that is how it happens. Now, a very simple thing I'm going to ask you. Have you heard about, I'm writing it, heart block? Any one of you, I mean, every one of you, in fact, would have heard heart block, right? First degree, second degree, third degree. How do you differentiate? How do you differentiate? PR interval is something the key to understand the heart block. Okay, first degree heart block, not a pathologically issue, not big pathological issue, but 2 degree, of course it is. And third degree, I'm saying there is no connection from AV node. I mean, it's not getting anything from the SA node. In that case, third degree heart block. It's completely down. Okay, so PR interval. There is a block. Heart block is nothing when no external potential is passing through. Correct. Start of P wave to start of QRS. Okay, fine. Then multiply by 0, 0. Okay, fine. Depend upon the electrical stimulation. That's fine. It's not electrical stimulation, in fact. I'm telling you, my dear friend, it is not electrical stimulation. It is not your Faraday current. Okay, Dr. Upasna Puri, it is not electrical stimulation, it is recording. Okay, no, not like that. It is not electrical stimulation. Keep in your mind, just read in your mind. It's the electrical recording of your own electric current flowing through the heart. Okay, is it clear? So it's okay, no problem. It's a definitely she's saying correct, electrical signal impairment. So that particular impairment, yes, that is true. So first degree is anyway, we say pathologically not much difficult, but second and third degree definitely, yeah. And that's all happens because of PR interval issue, all because of AV node issue. So I think we should not get any confusion hereafter on this. Now, after PR interval, we want to talk about our favorite Q wave. Okay, why it is our favorite? I'll tell you, because Q wave is a key for few diseases, and I can tell you that many a times we don't know what to do with the Q waves. Okay, so Q waves is not easily seen also, and yeah, normally it is seen in some of the leads, but I mean, again, as I told you, Q wave is something we have to understand why it has a negative deflection. So now the story, we will be talking about the Q wave. Q wave. Okay. Let us build our favorite schematic diagram. SA node, AV node. What happened here? Okay, Q wave. Okay. I'll make one more little better diagram with septum. It is one of my favorite diagram. The reason behind that, I make my students to learn about it even in my college with this. Okay. Okay. This is nothing. I'll tell you what it is. It is the apex of the heart down, and then this is the left ventricle area. This is the right ventricle area, and this is the Anybody? Intraventricular? Anybody can say me? Septum. Okay. Here is your AV node. All clear? Now, are we ready for the Q wave? Okay. So here, when the impulses from the AV node, it comes to the branches, what we say the bundle of his and then branches, and the bundle of his. Here, you see what happened. Here, left and right, we have a two branch, right? Everyone is agreed, right? Now, left and right, why it is so important to understand here, try to get the picture very clearly. Okay, left bundle branch has more potential. Okay, right bundle branch has less potential compared to the left bundle branch. Okay, so left bundle branch, I'll just check it out. Is there any question? Okay, left bundle branch, as I told you, it has a more potential. Now try to understand this very, very clearly here. Okay, why it is so important, I was telling you. So what will happen? It will emit the impulses, of course, this way, that way, wherever it will go. And from left side, it has to cross complete septum. Okay, then only it can come to the right, isn't it? Got my point? Right, it has to come to the right by crossing the complete septal wall, right? Then only it is possible. So you will ask me, what is so big deal in this? I'll tell you. One vector was like this, normal vector, which was coming like this. Got it? Now, anyway, one vector is coming like this, which is not very strong, right bundle branch. This is the left bundle branch. And then you have something, the resultant vector, which is coming like this. Well, now this resultant vector all the time, because it is not the story of one time, right? All the time getting suppressed by left bundle branch impulses toward the right branch. I mean, it has to cross the septum, as I told you. So it gets suppressed, right? It gets suppressed. So don't you think when it is a recording part, it is a positive, as I told you, please believe me, for some time, negative to positive. So when it is going away from the positive, away from the positive, the resultant one, it will show the negative deflection. So Q wave is negative because of that. You have any question, please ask me. Okay, well, why left has more potential, that we have to understand from the nature. And then pump heart pressure. Pump heart pressure is something like a ventricular, because you have a thick, really thick ventricular wall, which is on the left side. Okay, why it is travel from the left to right? As I told you, try to understand that. I told you left is also coming down, right is also coming down, left has more potential, okay? And if it is a left and the current will come like downward also, current will go this side also, and current will actually cross the septum wall and will go like this also. So left has a inclination on all going resultant vector. So you have like this, and this is your resultant vector. I'm telling you, you have a pressure of impulses coming from this side. It will push the impulses like this. So there is a vectorial representation. If you do that in recording wise, I'm telling you minus, and then here is a plus. So Q wave will have a showing little negativity, not much, it's very less. I think Q wave may not cross even the two small boxes, very, very less, but it happens. Okay, not clear. Again, I'm telling you. As I told you, AV node has a bundle differences, right? Left bundle branch, right bundle branch. You are very, very clear that left bundle branch impulses will pass through the septum. Right bundle also will go, but left has more potential, so it will suppress the right part, right? So we'll not say the suppression of right part. We'll talk about all the impulses having this is the resultant vector, and then because of constant more potential from the left side, the resultant vector will have a negativity effect. Okay, it will have a suppression effect in general. Naturally, that's the reason we have a small Q wave downward deflection. Yes, left has more action potential. That's it. What happens when there is a missing of heartbeat in ECG? What is the interpretation? I'm telling you, ECG beating the heart rate or anything, that is something our pathological part. Let us talk those things later. Okay. We have spoken a little bit about the heart block because it was the need of the time. I told you something about the PR interval that time. Now there is something what we have to speak about the Q wave. Now I'm sure that you have understood the Q wave too. Now the thing is, and those who asked about heartbeat missing from the ECG is, how do you know heartbeat in ECG? There is a formula, of course, but why? Like how? How do you know that? Okay, we'll come to that later because we have passed that first degree, second degree, everything. Now we'll not talk about that. Okay, what are the difference? We'll come to that later. Okay, so that is how you should understand. Q wave has a negative deflection for some time, not very big deflection. Okay, it's normal. And then after Q wave, we will be talking about uh, see, I'm not going Qrs complex and finishing my class so soon, right? I'm going into very minute, finer detail. Of course, you don't have to do ACG, but you should understand the principles. Principles is very common. You have to record between the two recording terminal of negative and positive or positive and negative. How you have to place that recording terminal? How do the technicians place? I will show you. You will remember for lifetime. There are 12 leads, but very easy way to remember. Don't worry about all those things. The only thing that you should learn about the principle. Principle is very simple. If negative to positive, if anything flows, the current flows, we say that a positive current is flowing. And from the positive to negative, if we have to record the same thing, it will show the negative deflection. But still, the current has flown. Okay, current has passed. So now we'll be talking about R wave. See how minute detail I have gone for, not QRS complex. I have gone for complete minute detail. Different Q, different R, different S, of course, different intervals. Why did I do that? I did it only so that if I do this class, you should understand much more into detail. Okay, let us draw our favorite heart. Okay, why favorite? I'm telling you because at least we understand this schematic diagram properly. We cannot draw all the time that sort of thing, or like anatomically. And yeah, well, now let us talk about it. So why it is a R wave? Did you notice as a AV? Of course, it will come down as it was giving the Q wave. Now from here, what happened? Please tell me. I will color the blue and then you can tell me what happened from here. From here, after the bundle sent current, current goes to this wall, right? So current goes like this. Now current has started flowing like this. See, current has going like this. Current has started going like this, right? So action potential will move from in to out, right? It was coming from this direction. Of course, you remember negative terminal, and here is a positive terminal. Trust me for some time. Okay, when they will be talking about the lead, the story will be different. But again, just trust me for some time. How do we record it? So from here, now you see the direction which was coming like this, Direction which was coming like this now started moving like this. Got point? Okay, moving like this. So what is happening here? Strong action potential is going to set because it is a ventricle. Okay, so now I think you remember many like V1 and V2. If you see that lead, the R wave is completely down, but magnitude is same, amplitude is same. Okay, so it all depends upon how do you read it, how do you record it. So we will come to that part later. First, try to understand why. And this here, you don't ask questions about like about the leads because it will get confused to you. So what I was saying you, one current, simple, try to understand. One current is going toward the left ventricle, one current which is going toward the right ventricle, say for example, and this is your resultant vector. Okay, it's not just one current, you have a multiple current. I'm not talking about still it has gone up, it has gone toward the Purkinje fiber, that's a different story. Right now it is going toward the left ventricle, it is going toward the right ventricle, and it is a resultant vector. Okay, it's a resultant vector. So net vector will be represented as Q R S and then T. I'm talking about this only. S. I'm talking about this R wave. Okay, why it is so strong? Why it is so strong? Because it has more muscles to get covered up. Okay, you have a thick wall. It's really thick, right? You have more muscles to come cover up. That impulses cover more muscles here. Okay, it has gone there, and once it has gone there, you know, it has gone there. Impulses has gone there. It is having the activity here. Action potential has steps in, and it has a strong R wave. That's the reason R wave magnitude is very, very strong. It moves toward positive. Heart rate calculation in ECG, I will be detailing you later. Don't worry, nothing will be missed. Okay, well, so I want your patience to be here. I want your attention to be here. Believe me, my friends, whatever the physical therapists need in day-to-day practice in their hospital, their teaching or anything, I may not leave anything of that sort. I will try to cover everything. How you calculate the ECG, I mean the heartbeat from the ECG, we have a three or four formula. I will tell you at least one or two formula. Don't worry about that. Just try to understand what I'm trying to say. Because left ventricle, as I told you, left ventricle has the more thicker wall. So definitely this resultant vector again will be persist more toward the left, right? Because you have a more thicker wall, more depolarization. So produce nice large graph. That is what you say is the R graph. Okay, R wave. Sorry, R wave. Okay. After this, we'll be talking about S wave. Okay, we'll not leave even the S wave and T wave. We'll see in little detail how S wave. Oh yes, again the same question. Now you will understand. This time you will understand completely why negative and positive deflection matters a lot. I'll tell you here. S wave, if you see in any of that ECG paper, I'm showing you from the site. P wave, PR interval. Okay, go to the Q, then RS, S wave, ST, and T gone. So this S wave, why it is into the down? Let us talk about it. Again, we'll be drawing our favorite heart like this. Thicker ventricular wall. We'll divide in 4 parts. Why it is happening? You just see that. Here, after depolarizing the ventricles, okay, after depolarizing these ventricles, both the side in fact, base of heart, okay, base of heart, which is somewhere this side, right? Because this we have taken as a apex. This is the heart apex. This is how, and this is the base, right? So what happened? The base of the heart in ventricle is still to get depolarized. You know, it's such a large wall that this they get depolarized, and still this particular part. Where are these waves going? Just try to imagine these waves. What I was saying you from the septum when it came like this, where these waves are going, going on top. Here when it start repolarizing again, it's still too depolarized. You know, at last too depolarized. I'm telling you, my friend, S wave is basically this part it indicates. You know, the ventricle's last part it indicates. You know what it is? You know why it is happening? Here, the current direction is like this, opposite. Opposite of what? Recording electrode, negative and positive. Here, what I said you, negative to positive, anything will go to the positive. Now, go to the positive like R, but or P. But what happened here? Here, what is in case of S, what is happening? Just see that. In case of S, if you see, current direction is like this, isn't it? Current direction is like this, isn't it? Tell me from your chat box if you don't understand. Current direction is like this. Current is going like this. After septum, the current is going like this. From the ventricles, current, I'm talking about this particular part of the ventricle, where it is at the last, the base of the heart, base of the ventricle. When it goes, that time the current direction is like this, both the sides. Resultant vector will be what? Exactly opposite to the negative to positive. So negative to positive, current is anyway flowing, but recording terminal, because the vector has gone opposite, so the baseline, remember the isoelectric line, it will go below the baseline. Okay, so S wave will be like this before it goes up. S wave. Is it okay? Understood this? I'll just check out the question. Please repeat. Okay, fine. Please explain. Yes. I'm. Those who have understood, fine, can revise. Those who have not understood, please see that. I said after the R wave, what happened? Depolarization already happened. Now it will start getting repolarized, right? So this part start get repolarized, but still this part is still to get depolarized, because through the Purkinje fibers, basically the current is still going on. Where are these people going? I mean, where are these current going on? It is going up, and to depolarize this. Already it has depolarized, but now according to the recording terminal, just see what is the vector. Direction is like this. Okay, say for example, this side L, direction is DL. So direction is DL like this. This side I'll say DR. Okay, direction of right is like this. So don't you think it is that this direction, there will be a resultant vector, right? Resultant vector. Resultant is like this. But if you check out the resultant on this particular what we say that page, just a sec. If you check out the resultant on this particular thing, resultant will be like this. Okay, though current was going like this, one direction, current was going like this, but the resultant will never come like this, right? It will go like this only, right? Resultant will come like this. So current ka resultant, you don't worry about what is that in right or left. What I'm saying, you resultant of the current, there are many currents flowing this side and this side. Resultant of current will go like this. So this direction, what is the direction? What is the direction? The direction is exactly opposite to the negative to positive. Since it is a exactly opposite, what will happen? It will definitely, the wave will get drawn, but it will go to the negative, right? So isoelectric line, it will go down. That is the reason S wave is negative. Is there any question? Is there any kind of clarification still you want? Reverse direction? Yes, it is a reverse direction, but it is a resultant current. It's the imaginary thing I have taken. In fact, it is a recording part of that I have taken, that when you have a recording terminal, which is from the negative to positive, of course, the current is going up. So there are many currents going up. So what is the resultant current? Resultant current is exactly opposite to the flowing, like a negative to positive. That is how it has the impact of negative deflection. Though the current has flown, so there is a wave, right? current has flown, so there is a wave. There is a demarcated S wave, right? But it has gone down. Why? Because the resultant current was the negative of the direction of real recording terminal, right? So that is how we have to understand the thing. I was talking about S wave right now. Now we will go to the our I'll see if I can talk about ST interval also. I will not give any break right now. I'm not sure if CEO sir is listening or he is busy in other webinar right now. We have going on something for some special students who joined. Dr. Divakar? Oh, I think they are busy. No problem. I'll be talking about ST interval. Why ST interval happens? Signal is going from positive to negative. Now you understood. Okay. Well, so now will be, let us see ST interval. Okay. ST interval is what? What is ST interval? Because once you understand that, after that, another half an hour will finish everything. Now, same kind of hard. If you want to draw, we can draw. But the thing is like, okay, now you have mastered over this, right? So entire ventricle is ventricles is depolarized, means all are set, right? Now what happened? But it has no repolarization still. Okay, no repolarization. Okay, so there is no potential, right? So there is no potential for some time. That is the reason isoelectric line keeping silent after the S wave come into picture. Before the T wave starts, before the T waves start, you have a ST interval. That is the key reason it is keeping silent, just like your PR interval, right? The ST segment is mostly it shows with the isoelectric line, which is actually okay. Anyway, we'll talk about the leads little later. It is actually normal in the V1 kind of thing, or like normally elevated also. That we'll talk little later. So ST segment is very, very important when we have to choose the pathology. Okay, so it has not still repolarized. So unless it is a repolarized, it will be it will show no, it will show, like a whole ventricle has to get repolarized. That is how it will. Unless that gets sets in, it will show like this. So now after the ST, ST in we were talking about ST interval. Now last T wave. Okay, T wave. So T wave is what? As you have understood from the first slide or maybe the third slide itself, so the T wave is nothing. It's a ventricular repolarization. It is equally very, very important because T wave gives us a lot of idea about it. Okay, so T wave. Okay, T wave is what? Entire ventricle is getting repolarized. Okay, entire ventricle, either it's a left ventricle or right ventricle, it is getting repolarized. That means positive flipping to negative, positive flipping to negative, positive flipping to negative, positive flipping to negative. All positive gets into negative, negative, negative. That is how negative is away from positive. Negative changes moving toward the like upward direction. That is the positive deflection, right? You got my point. See what happened here. Negative, what I was saying, you positive flipping to negative, right? Positive flipping to negative, positive flipping to negative. So what happened here? Negative is away from positive. Okay, go like this, go like this, go like this. Okay, so what happened here? If you see the current resultant vector, everything is going like this. Okay, so what is happening? The resultant vector is like this. Okay, small currents, sorry, there are many currents like this. It is happening across the ventricles. So what is the resultant current? It is happening like this. So if you see the recording terminal, well, it flows from negative to positive, right? It flows from negative to positive, so definitely it is a positive deflection. T wave. Repolarization, I'm talking about ventricular repolarization, nothing to be lag period. Can you please repeat ST wave? No, there is no ST wave, sorry, there is no ST wave. It was a ST segment. I said ST interval is something when the ventricular is depolarized, because I told you ventricular is a large thing. So suppose this is a completely depolarized, still it has not got repolarized, right? So complete big mass getting repolarized is something that it doesn't get any potential for some time. That is how the ST segment matters. So it's what ST is what, like, after S wave, before starting T, it is keeping silent for some time. Why it is keeping silent for some time? Because it is not getting potential, so it is having an isoelectric line. Simple, just like PR. So that is the reason ST is so important. So if you talk about ST segment, more than this, we'll talk a little later. Okay, fine. Now the T wave, as I told you, all negative flipping to positive. So not more than that you have to understand. So all direction is like this. This is enough to understand how the small, like everywhere the current getting repolarized or negative get moving to positive, and the direction is almost similar from negative to positive. So I mean, talking about the resultant vector, which is in the direction, in the alignment of uh, that particular thing, what we say that current. So that is how it is showing the positive deflection. I will check T wave. Okay, I told you T wave just now, I repeated. Yeah. So now the next part is to talk more about leads of ECG. Okay, leads of ECG. I'm telling you there are 12 leads. Okay, let me write here so that you can. 12 leads. Do you know? Very easy to remember. 3 types of 12 leads. One is bipolar, another is augmented. What is this? I'll explain you properly, don't worry. And other is, they say chest lead, you say precordial. The medical word we should use more while teaching or having practice, or even it is in normal language, they say chest lead. Okay, so there are 6 chest lead, there are 3 augmented, there are 3 bipolar. As the name suggests, bipolar, let us discuss one by one. Bipolar. Okay, as the name suggests, it needs what? 2 poles, right? Okay, fine. I'm drawing a simple human being. Okay, schematic diagram. Don't laugh if it is getting not correct. Okay, it is just for your understanding. He's not handicapped, don't worry. And hope everybody is able to see that. Okay, so this is, okay, I'll change the color so that you can understand better. So now this is right arm, this is left arm, and this is, of course, if that is left arm, then it is a left foot or left leg. Okay, we'll not use the lower limb right now for some reason. Okay, so here how it is important. Say for example, it is a negative, okay, and this foot we have taken as a positive electrode, okay, and here positive as well as negative. Yeah, lead 1, 2, and 3. You're right. I was coming to that. So now, there is a misery potential will be between these leads, isn't it? So now, lead 1, lead 2, and lead 3. So lead 1 will use the Roman letter 1. It is between the potential of two arms. Yes, Dr. Karthik, you have any question you can ask? Because raising hands will have a different, this one, I can't understand what you want. So this is the lead 1. Cool. Between two arms, we measure the potential. Now we have a lead 2. Okay. This we measure between right arm to left foot. And then we have definitely the lead 3, which is between the left arm and left foot. This particular potential we are going to measure, lead 3. Okay. These all are bipolar lead. And somebody told it is an Ethovian triangle. That's correct. That's definitely correct. Very good. It is an Ethovian triangle. And there is a law also, I think. Ethovian triangle. There is a law also. If you include first and third, it will go to second. Okay. How it happens, I'll tell you. Okay. So first, what are we going to do with the first? My dear friend, I will draw a heart here. You can just see in the human heart. Here I have just drawn a small schematic diagram. So what are you going to do here? With the lead 1, we are going to see what? Always remember, we are going to see from the positive side. Okay, because we want the current to come like and so what it is. But it's a customary to understand it is from the positive side. Connecting two arms in lead 1. Yeah. So what is happening from the positive side? So lead 1 is basically for your left lateral view, isn't it? Left, it is for the left lateral view for lead 1. Lead 1 is what? Left lateral view. There are many views for the heart. I'll tell you how it is. Okay, so from this bipolar lead, we come to know this. Then now you are good enough to understand what is happening between the right arm and left foot. What are you going to do? From here, you are going to see, right? Wherever there is a positive, you are going to see from there. So what are you going to see? You are going to see this part of the heart. So basically with the lead 2, you are going to see the inferior view, right? Inferior view of the heart, how it is happening, right? So so now again, as I told you, once you understand that these two views, inferior view, very correct. So these two views, that's my game is over here. Now we will go for the what we say, the unipolar or augmented leads, right? No, no, there was no double positive. You can see there is a negative also that side on the left arm side. Okay, so once you go with the text, proper text, when you try to understand the leads, no, if you go to the proper text, you will understand why it is important. It is just a bipolar lead. Only 3 leads we are connecting in 3 sides, and we are having a this what we say, view of inferior as well as the left lateral view. Okay, and always remember Ethovian triangle, we have to see always from the positive side. Okay, so now let us talk about the augmented leads, then we will discuss some more on this. Okay, you have, as I've told, three augmented. So we have a unipolar also, we can say that unipolar. Okay, now I'm not sitting in the clinic, otherwise I would have shown you by like how do we actually see. Okay, let us talk about how this unipolar lead has been arranged. Yes, you're right, AVR, LLF, everything. Yes, I'll tell you how it is. Okay, I'll tell you. If you see from the lead 3, I told you we see anything from the positive side. Okay, left foot has been given positive. Okay, has been given positive. So we have a two views of inferior. So we are going to see the heart from the inferior. That is the reason. Lead 3, I did not detail you. Anyway, now come to this, and then we'll talk other things later. Number 1, I'll draw 3 triangle. You will understand that how it is. What it is, I'll just explain you. Have patience. Okay, all these heart are diagrammatic explanation. Okay, here, as I told you, it is a right arm. Same picture you would have drawn in your notebook. You can follow. In fact, okay, this left foot or limb, whatever you say, left foot. In fact, left arm, right arm. Okay. Now the heart is like this. Well, now here, how will you see? Okay, why it is augmented and unipolar? You know that it is mainly to have only one pole in mind, means augmented. Okay, only one pole in mind. How it is happening, I'll tell you. I told you about lead 3 just now. I think you did not hear. Okay, what is happening here? Right arm positive, this is negative, this is negative. Say for example, okay, this is what we say AVR. Okay, positive is something where you have to see toward the, okay, how it is possible. You see, we have kept a positive lead here, negative lead here, negative here. How it is possible? Resultant vector is what? Suppose this is the one vector, this is the one vector. What is the resultant vector? What is the resultant vector? Resultant vector is somewhere here. Don't you think the other view has been created for the heart? You got my point. Resultant vector of these two, right now is this particular thing, and you are able to see the heart from this side. Okay, this is your eye. Say for example, eye. Of course, you don't keep your eye here, but recording is like this. Okay, so once you keep your eye, you are seeing your heart from this side. Okay, okay, keep in the mind, positive is looking toward negative. That keep in the mind. Eye is here, so you are seeing this part of heart. Okay, what is that? This part, part, right lateral superior part, right? The same way, when you talk about AVL, what is AVL? It is nothing. It is a augmented for the left. So here what will happen? Positive will come here, negative. I know this is little tricky for you, but still try to understand that. Try to understand that. Okay, the resultant vector will come like this. So you are able to see from heart from this side. So it is a left superior part. So it is just to create a different potential, different view. View means to create different type of potential. Scientists have created a different list. You don't have to do anything. ECG does doing everything for you. Just try to understand how it happens. This time positive is there at leg. Okay. Negative is here, negative is here. What is the resultant part? Resultant vector is this. Okay, keep your eye here, means the record from here, eye. Okay, what will happen? You will be able to see heart from definitely down. Okay, how? Apex side, isn't it? So that is how these three leads are created, augmented. I know it's difficult. Try to understand. This is done only unipolar system. It has been done only to create a different views for the heart. I mean to say it has to record the potential. As you know that two types of potentials you have recorded in bipolar. Here you have a three more types of potentials to be recorded. Clear? So it's all about the resultant vector and different view of the heart. You do it. Is it clear? Okay, nothing else. The most important part is coming now. Second one is nothing. See what happened. AVL, left arm. Okay, left arm. Okay, sorry. Yeah, left arm. So here what happened? Here you see left arm. How do you do that? You have one here. You have a one view here. Okay, so resultant view is like this. So from the positive, if you see, you'll be able to find this part of the heart. Okay, the same way here, if you want to say, for example, you want to make it a, just a sec, you want to make it AVF, foot. How will you do that? You have already connected two bipolar leads here, negative, negative, and then positive. Don't compare this with your earlier bipolar leads. I'm telling you, this is the new way of developing that. It doesn't happen. They use always the this particular part, the resultant part. Okay, so it is happening what? Here is positive, here is negative, here is negative. So resultant vector will be in between. Okay, so you will be able to see the heart from here, from down, apex. So I mean to say, earlier you had just two views. Now you have, say for example, this is your heart. So you have now another views also. Earlier had this, earlier you had this. Okay, now you'll be able to have this, you'll be able to have this. So how many views you create, that much it is better for you. No, don't get confused with the I have just kept to make you understand. You can't keep I and record, right? It is just to your understanding. See how the lead unipolar leads has been formed. It is not these all are just depending upon the resultant vector. Okay, it is not like that you have to keep your eye and do it. No, not like that. It is just to create a different view. Got my point? It is just to create a different view like this. It is there is a vector quantity, so you have a resultant vector like this. From this angle you have a resultant vector because you had a one bipolar here, say for example one bipolar here, but other views, how will you get it? So they created one of the resultant here, one of the resultant here, one of the resultant here. That's it. Three more views. That's it, nothing else. If you don't understand also, no problem. It is just a principle of recording. It has nothing to do with the eye. So I did not realize it is 8 o'clock. If it is urgent for you, any class or anything, I think you can leave, but still it will go for another not less than 45 minutes. I am going very slow. I told you earlier. So it will take time for me. I want more time to explaining ECG. So I have chosen this Sunday. Next Sunday, I may have holiday. It will take another 45 minutes minimum for me to finish that. Because I have gone very slow. Don't get confused. Those who are getting confused, please try to understand it is the augmented lead or three more views just to create your own heart having, like some more views, some more recordings have been created. One more time, I'll explain you simple. Suppose this is your heart. Okay, this is your heart. What happened? You had a two views by bipolar, right? One view is two recordings, one recording, two recording, but you want to record something more. You want to know something deeply. So what happened? They created a resultant vector like augmented lead. Now you have a 3, 4, 5, that sort of recordings you have, right? Now still the ventricular is waiting. Why are you worried? Another 6 views we have. Oh, yes. You have to check through the ECG graph. Once I will bring the ECG graph, you will see that you have every leads separately drawn over ECG graph. Every lead separately, every lead. You have every lead separately there. Don't worry about it. Okay, no worries. Well, so after this, now we have the most important. Remember that the leads. I mean, one of the most important, in fact, very important for physiotherapists, I believe, the chest leads. What you say, the precordial leads. Those who are confused, I told you it is just to create the new version of recording. 3 more version of recording. How much you record, that is better, right? More data, much better. This one. Okay, fine. Now, how do we record the ventricles? Okay. I'm drawing here a simple manubrium sterni. Every one of you are aware with the rib cage. So you have a ribs here, right? You have a rib here. Schematic diagram I'm doing. Okay. Okay. Now, how do you find? Yeah. How do you find intercostal spaces in general? You go to the manubrium sterni, right? You go to the manubrium sterni, right? Correct, no? Then you come to the, like go little downward, then you find there is a angular prominence here. What you say, the angle of sternum, right? Is it? Yeah. So from there, if you take right or left turn, you find the second rib. Correct or not? Nobody's answering. I think you are sleepy now, right? Second then what happened down? I mean, just descendant to second rib, you have a second intercostal space, right? Second intercostal space. Now you count second intercostal space, third intercostal space, fourth intercostal space. Come to the fourth intercostal space and apply one lead called V1. Okay, V1. Apply that lead called V1 in fourth intercostal space, right hand side. Should I color that? Just a sec. So this is the sorry, exactly, sorry here. So it got a bit little bigger. So what I want to say you that right side you have a V1. Then you come to this side, left side, exactly in the fourth intercostal space. Then you have a V2. Okay. Then you have V2. Okay. And then just forget V3 for some time. Come to the V4. Okay. V4 should be in the mid axillary line. Okay, V4 should be mid axillary line in fifth intercostal space. Okay, so this is your V4 in fact. Okay, fifth intercostal space, left side in the middle axillary line, you have a V4. Now go to the V5. V5, you know where it is? It is in the anterior axillary line in the fifth intercostal space. Okay, it is in the fifth intercostal space. So it was a, okay, I'll just draw it here. V1 and V1 fourth intercostal space, right side. V2 fourth intercostal space, left side. Correct? Exactly close to the sternum. Well, now V3 we will not talk for some time. V4 is exactly the at the mid sorry, V4 is at mid-clavicular line. That is the place, mid-clavicular line at intercostal space is what? Fifth intercostal space, right? Again, come to the V5. V5 is basically with the anterior axillary line on the fifth intercostal space. And V6 is also the intercostal space will be the fifth only. It will be in the mid axillary line. Okay. So V1, V2, V3, V4, V5, and V6. Understood? Or any confusion is there? Again, I'll repeat it, or you want me to write? I'll write it. Yeah, fine. Mid-clavicular. Yes, fine. Okay. Now, between the V2 and V4, just place the V3. No problem. That is the placement of V3. No specific thing. Okay. Again, I'm repeating. V1, fourth intercostal space, right side of sternum. V2, fourth intercostal space, left side of sternum. Okay, this is the intercostal space. Say, for example, which intercostal space it is? Fourth. Now what happened? Come to the V4, V5, V6. What happened here? Intercostal space will change. It will come to the fifth intercostal space. Okay, V4, V5, V6, all three will be in the fifth intercostal space. Only the position will differ. V4 will be into the mid clavicular line. Okay, imaginary line again. Mid clavicular line. Anterior axillary line is placed for the V5 and mid axillary line for the V6. Is it clear to every one of you? Okay. Now, once you are clear with this, let us erase this and then I'll tell you what it is. Just a minute, let me erase it. Sorry, I delayed every one of you, but the topic is like this. If you don't understand and read, it is something that you're reading from the somewhere and then you're forgetting it. I don't want you to do that. Once you understand the principle, it will be easy for you to. Well, once again, I'll revise the V leads. I mean the ventricular lead. I mean, sorry, chest leads. So what happened here? I told you V1, fourth intercostal space, right side of sternum. V2, fourth intercostal space, left side of sternum. V3, I'll talk later. V4, fifth intercostal space, mid clavicular line, it should come. Okay. V5, again fifth intercostal space, anterior axillary line. V6, fifth intercostal space, mid axillary line. Okay. V3, I think it is between V2 and V4. To draw diagram, as I told you, like this. Okay. V1, V2, V3, V4, V5, V6. Simple. Very, very simple. I don't want to complicate it. Now, V1 and V2 is taking what? It is taking electrical activities from the septum. Right? It is taking from the septum. Now, V3, of course, from the septum. And then V3 and V4 will be anterior wall of the heart, right? Anterior wall of the heart. And V5, V6 will be the, not posterior, it will be the left lateral wall, right? Because it is completely on the mid-clavicular line. I'm sure that you know how to take the apex beat and all those things in assessment. If you have not, then you can join my class on the assessment if sometime it happens. Okay, well, so once you know about the this precordial leaves, my job is 70% to 80% done. Now we will come here and we'll talk about more for what is the thing you should know. Suppose you don't get to know more about uh, like a graphs or something like that. That anyway, I'm telling you, with this 2 hours or 3 hours class, I'm not able to make everybody understand 100% unless you go and revise these things. Because unless you revise anything, it doesn't come into the mind, at least for my thing. Okay. So now I will tell you certain facts or kind of rules. I will not say rules, but anyway, facts to remember for normal ECG graphing. What is that? I will be writing. Please write down in the paper. Okay. There are some 7 or 8, or maybe, yeah, 7 or 8, I think maximum. First is what? You have to remember about the P wave. Okay. Again, we will go through this, but I'm just telling you how first. So, like what happened? To learn about, say, for example, to learn about your PFT thing, whether it is normal or abnormal, first you learn about the normal PFT thing, isn't it? You don't learn about always the abnormal things, right? So P wave, what is P wave? It is upright, okay? It is upright and seen in the lead 1, 2, V2 to V6, okay? This you should keep in the mind. Always remember that. Okay, if you want to note it down, please note it down because I'll be explaining one rule at a time. That will be better. Always upright. Lead V1. Yeah, well, well. Second is, let us talk about, yeah, everybody has written about the P wave. I'm giving you these tips for the physios, mostly. So don't have to worry about. If you can learn those graphs and all later, no problem. Second is, a second fact is very important is what? After P, what happened? PR interval. How should be the PR interval? 0.1 to 0.2 second. That should be. So if you see on the graph paper, this is 3 to 5 small square. You remember 0.04 into 5 is equal to 0.2. I told you 0.04 will be the single small square shape, right? Yeah. Well, so this thing keep in the mind. PR interval is what? You know, how we know about the PR interval. What is the PR interval speciality? So it is 0.12 to 0. Just a minute. There's some problem with this slide. We'll change the slide, no problem. So third point, every one of you, please note it down. Third point, every one of you, please note it down, is about our favorite Q wave. What should be the specialty of normal Q wave? Okay, it should be just 0.04 second. Okay, 0.04 second. So it's about 1 small square or maximum 2 small square, not more than that. Okay, so that is a normal. But normally you don't get no Q wave is seen where? Lead 1, lead 2, and ventricular. Of course, you can never see the Q wave, V2 to V6. You don't see the Q waves. these facts keep in the mind, because these are the, okay, please repeat the P wave. Okay, fine. I'll repeat here only. Please take it down. P wave, I told about the P wave is always upright. Okay. And you can see nicely in lead 1, lead 2, V2 to V6. Okay. So now, after this, we will be more into, after Q wave, what is that? What should be there? Don't tell me the R wave. I want you to listen the proper thing first. Proper thing is what? QRS complex. So in QRS complex, as I told you, today I'm not here just to give you the brief explanation. I'm actually going to the very detail. So let us talk about QRS complex first. What should be the QRS complex? It should be 2.5 small square, that is 0.12 second. 2.5 to 4 mostly 3, 2.5 to 3, that is the small square it should be, and then it should be less than that. Okay, QRS complex 0.12 second. Okay, now fourth thing is here only I'll write, you can see that I will not all the time, I will not. R wave. Okay, it should be, see, R wave is very important for physios. Reason behind these all are things are very simple to remember. V1 to V5, you will see constant growth of R wave. I'll show you even the normal ECG how it works. So R wave you will find from V1 like this, V2 you'll find like this, V3 is like this. So constantly it will grow like this. Okay, that is the like major, I mean the bigger feature I can tell you with the with the R wave. And then now let us talk about S wave. Here only I'll talk about the S wave. S wave, I will not tell you much to remember. You can just see S wave generally increases. Sorry, it was T. Sorry, I'm really sorry. S, what is happening? R, yeah, this is the S wave, right? It increases between V1 to V3. Now, if you ask me why it is increases, why it is decreases, for past 2 hours, I am discussing about how ventricular repolarization, depolarization take place. If you correlate with that, that is your homework, okay? Then you will find why V1 to V3 as graph increases, okay? And it is not seen in V6. Anybody can tell me the reason why it is not seen in the V6? It is not seen in the V6. S is not seen in the V6. Why? Okay, that is your homework. You can do at home, no problem. But you will be able to easily correlate. Next important point is, very important is ST segment. Please note it down, ST segment. Okay, normally ST segment remains on the isoelectric line, right? That's what I told you, isoelectric line, ST segment, before starting the T wave. Okay, S wave and T wave. That is the part you say the ST segment. Okay, now ST segment of V1 and V2, it is normal to elevate. It will go elevated in normal. Don't worry, V1 and V2 it happens because if you remember, I was telling you V1 and V2 is kept basically on what? Right ventricular wall. Isn't it true? And right ventricular wall is something thinner than the left ventricular wall. So it is possible that okay, R wave I'll repeat again. Just wait. Don't just wait. Don't distract me. Otherwise I'll forget it. What I was saying you, ST segment V1 and V2 it is little elevated. Why? Because V1 and V2 is at the right wall, right? It's at the right wall if you see V1 and V2. So what happened? And the part is also thin compared to this thickness in left. It is thin. So ST is all about potential generation. Potential has not generated. So of course here it will start getting repolarized early. Potential will get generate early. So V1 and V2 is very normal to happen little elevated. Okay, that's fine. That's completely fine. Pathologically normal. Okay, but in other lead, if it's happening, the ST elevation, I'm sure you would have heard ST elevation. Okay, they ask questions also across the globe. ST elevation is very important. When I'll come to my next part today, you will have all doubts clear. You know, ST elevation, if it is happening in V1 and V2, normal. Other leads, if it is happening, definitely some problem is there. What is the problem? We'll learn it. Okay, now T wave. Okay, fine. Before that, somebody asked me about the R wave. What do you want to know about R wave? This was Q, this is R, and this was S. So what do you want to know about the R? I was saying you R for a physio just to see that. I mean, for everybody, but I'm just talking about physio because I'm teaching physios. V1 to V5, what happens? Size of R, it keeps increasing. Why? Just try to understand. V1, V2, V3, V4, V5, V6, right? So now you see why did I tell that V1 to V5 it keep increasing? Just try to understand. Because you have a thicker wall, right? From the right to left, if you move, you have a thicker wall. If you have a more thicker wall, definitely the rise of R will be very sharp and very clear, nice graph. It will come. Got my point? Those who asked are. Okay, fine. Now, next point, you note it down. Here only I'll write it down. I will not go for other slide. You can write it down. T wave. What is the problem with the T wave? What you should understand with the T wave? T wave is upright, okay, in lead like 1, lead like 2, and of course V2 to V6. Repolarization, right? So repolarization, always it is a T wave like this. Okay, if it is a T inversion, there is another problem. It is generally in these leads, it is fine. Okay, fine. So these many things I'm telling you just to understand your point. I know it's little. Okay, R wave, as I told you, just a sec, I will do that. Just a minute. Those who asked R wave, just a minute. I will explain it again, R wave, but make sure that time is also moving up and many people are getting worried about to move. So take care of them also. I'll just explain the R wave. If you have any issues, ask me in the group. I will explain you later. But okay, R wave. Once again, see the R wave just for 30 seconds. I'll tell you. You should remember that. I was telling R wave. R wave is what? Q, R, and sorry, Q, R, and then S, and then again T, right? P, sorry, like that. P, and then Q, R, S, T. Why it is happening like this? I told from V1 to V5, R wave size amplitude, it means it increases. If you see the different graph, if you see the V1 lead graph, the V2 graph will be like this. The V3 will be even more. V4 will be even more. Why? Just try to understand this. From here, right atrium, right ventricle to left ventricle, there is more thickness of the wall. So what will happen? It will definitely need more and more rise of graph. Okay, more depolarization happens because of more mass. Simple. Try to understand that. Okay. Well, now after this, I think the slides have been a bit dirty, so let us see if we can move to another side. Yeah. So this is cool. Now here, see a new picture of, okay, after T wave. I think after T wave, you should not remember anything. You can remember certain things like what, the important point after T wave, what you have to remember is Qrs complex and T wave, okay, should always follow same direction. Same direction, QRS and T wave. Okay. Why? It's very simple. After depolarization, you should have repolarization. That's it, nothing else. Now, lead 1 and lead 2, another important point. Lead 1, this much you should remember. Lead 1 and lead 2 should have a positive. I don't know what is the problem. It is not working. Yeah, positive waves. That you should keep in the mind. Okay. Now, last important point. I have a video also. I think the video is there on the YouTube also. If it is possible, I'll search it and give to you. AVR. Okay. These augmented lead graph, when you see, let me tell you, everything, my dear friends, everything here should be downward. Everything should be downward. Keep this much in the mind. Many things will be solved. Okay. Then the next part is only for 15 minutes we'll be talking. The same thing will get revised, but this was just to know the normal thing. If you can note it down, if you don't note it down, also no problem. But you will get it somewhere on the YouTube or maybe Google, and not a problem. I just try to summarize it and then told you. But next part, what we are going to talk, that will be the last part of today, and that will finish our stuff properly. Okay, my question is, how to read ECG in just 10 to 15 minutes of time. Okay, just for physio perspective, it is completely physio perspective. I am telling you, I don't want to talk anything else regarding anyone else. Physio perspective, if I see my stroke patient ECG, I want to learn what happened to it. So like 10 to 15 minutes, you can just see the T wave. I did not tell anything else. I think I told you the upright, it should be upright, and especially in the lead like 1 and 2, and then even V2 to V6, it's not down. T wave inversion is not possible here. Okay. How will you read? What you have to do, you have to start with first thing. If you want to write it down, you can write it down. I have no issues. Rhythm. How will you find rhythm for your patient? ECG. Okay. I will be changing the slide just to show you the rhythm. Okay. Let us understand this first. Rhythm could be either regular or it is a irregular. So what is sinus arrhythmia? Anybody sinus arrhythmia? Okay, forget about sinus arrhythmia. We don't have enough time to discuss this. So always check RR interval. Okay, I will take you to my like a pre-designed slide so that you will be able to have a better view. Yeah, let us. I'm not sure whether everybody of you are able to see that, but see here. See here, sinus rhythm. Okay, how it is going. So what you have to do, basically, you have to select the RR level. Okay, R, 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 R. What you do, okay, what you do, you just try to take a normal paper and just keep it here. Okay, just keep it here, and you just mark one, mark this. That's it. Now bring this paper and try to keep the paper here. Okay, and see that whether this the same distance is getting maintained. You got my point? Suppose you are keeping a piece of paper here, you mark the R wave here, R wave here. Now the same paper, you bring it here and then check whether it's the same distance, or you can do what? You can check it with the some more number of R waves and then try to measure the distance between the scale, this, and this. All are equal. That means it is a normal sinus rhythm. Very simple. Got my point? Very simple. Just try to check the RR level. That's it. Nothing else. Once you check the RR level, your work is done. Okay. So I told you, just try to understand these points. I'm telling you, you will have a lot of benefit to understand that. So rhythm, RR interval you check. Okay. If it is like a atrial fibrillation, what will happen? You know, atrial flutter or atrial flutter is different. I will tell you about the atrial fibrillation. Atrial fibrillation, in that case, your P wave like this. Okay, like this. P wave is like this. Okay, every P wave what you have, you know, before RS, you will find this P wave like this. Fibrillation, fibrillate, right? Fibrillate. You can see from the Google, there are images for atrial fibrillation. It will give you better idea. Okay, if it is a regularly irregular, then it is definitely a heart block. If you remember, I was telling you irregularly regular is basically the heart block symptom. I'll just find out, is there anybody murmuring sound? Okay, I will not talk about much to the sound because we have got already delayed. Yeah, you're right. Rhythm. Okay, after rhythm, let us talk about okay, because very important, another 5-6 points, then we will have a leave for the day. Sorry, I held up you everybody too late. Okay, so second part is what we are going to see is after rhythm, somebody had asked me the heartbeat. Okay, how to calculate heartbeat from that? I'm telling you, if you have a regular ECG, suppose in the impression you find nothing abnormal, ECG is quite regular, in that case, do one thing, take 300 divided by, get 300 divided by RR interval, but interval should not be in the terms of seconds or milliseconds, it should be in the term of number of large boxes. Remember, boxes, number of large boxes. So suppose you have a P wave, Q wave, R, S, and then T again. Again, you are going, again, you have a P wave, Q wave, R, S. Again, you are going T wave again. So what happened here? You will have a number of boxes, right? Right? You will have. So once you calculate partial or complete 1, 2, 3, 4, 5, 6, or say for example 5, it will not be so much 5. So what happened? 300 by 5, that is about 60, right? 60 beat per minute. Okay, that is the regular one. I'm not talking about regular now. Now come to irregular. If the ECG is irregular, if it is a irregular heartbeat, how will you calculate that heart rate? Anybody has any idea? Irregular heart rate, how will you calculate? What you have to do, number of R waves, you have to multiply with the 10. Number of R waves multiplied by 10. That's it. Okay, but make sure that you have a 6-second ECG paper. Okay, normally 6-second ECG paper comes, but I'm just telling you 6 seconds ECG paper, if you have, easily you will be able to find out the number, like how to calculate the heartbeat from the ECG. All right. So now after this, we'll be moving to the next characteristic for physiotherapists. How can they read the news? I mean, how can they read the news of ECG of a patient? How it is possible to read something different? Okay. I have not explained about the axis because axis would have taken another 15 to 20 minutes. Well, now we will describe little bit about the axis. Not much. If I describe, I told you it will take much time, but I will tell you what is axis. Okay, axis. What is axis? I'm telling you, drill in your mind one picture I'm going to give you today. Drill in the mind. It's very easy. Once you see that picture, if you want, I'll save and I'll send you also on the group also. Yeah, this is the axis. Okay, normally heart is like this, and then you have something called, somebody's asking certificate link. Are you joining for certificate? My simple question is, you'll get that link anytime during the event. Okay, see, this is the axis. Drill in your mind. There is one more beautiful image is there with me. I could not fit today here. Uh, that is even better image than this, but I'll try to send at least this. See, all the leads are here. Okay, all the leads. So generally minus 30 to 110 degree, that is the general cardiac axis. Okay, that is a general cardiac axis. If you don't understand, don't break your head, but I'm just telling you that. Okay, so what happened here? Okay, what happened here? Choose two perpendicular lines for knowing what it is. I'll tell you, it is very important. Left axis deviation, right axis deviation. Okay, how it is possible? Left axis deviation, right axis deviation. See, they have nicely explained this. Left axis deviation, right axis deviation. Normal electrical axis ranges between minus 30 to 90 degrees. Sorry, it's not 110. Many cases it was 110. Sorry, it is sorry, it's 10 degree. This is a normal axis, normal electrical axis. Okay, electrical axis is nothing. It's a resultant vector of different kind of leads which has been tried. Well, now what happened here? Left axis deviation. How it is possible? Okay, here if it is a QRS lead, okay, and that is in the positive, and normal AVF, what you say the lead is into the negative, it will be mostly to the left axis deviation. Okay, and right axis deviation, if you want to understand, you can understand by the YouTube also. You have a good videos on that. Here what happened, QRS factor goes negative and lead 1 is going to the positive. Okay, lead 1 is going to be positive. So in that case what happened, it travels like this and then it goes for right axis deviation. Anyway, this thing if you don't understand, no problem. There is no need to understand in terms of reading the ECG, I mean in general, but yeah, if you understand, you can read always better and better. Okay, so I was talking about axis. Forget about axis now anymore. We'll not talk about axis. Okay, axis is okay. Axis, that image, if you keep in the mind, if you want, I'll send you that image also. Now, next characteristic for physio, like next thing what the physio should know about learning ECG. If you know axis, always good, but if you know about characteristic of P wave, just now you, I don't know what is the problem, just now you learned about the P wave. Okay, P wave height, P wave width, very important. Okay, height is generally 2.5 mm, especially in lead 2. Okay, and lead 1 it could be about 1.5 mm. Now don't ask me why it is a different, because it depends upon where they get repolarized, where they get depolarized. Width is generally 0.12 second. Okay, so what happened here? P, remember P, that is the P pulmonary valve. Okay, if that is the problem, then generally P wave goes more higher. So if it is a high P wave, that means it is a right atrial enlargement. Okay, if it is a wide P wave, that means it is a mitral. M for mitral valve, remember, M for mitral. So it will be the left atrial enlargement. Okay, if you correlate the depolarization, repolarization, and axis theory, it is very easy to understand. Okay, tall P waves, you'll be able to see into the right atrial enlargement. Wide P waves, mostly into the left atrial enlargement. Okay, I want to finish some of more characteristics very fast so that you don't get cost with the more time. Okay, so that is how you should remember that left and right. Okay, after P wave, the most important part is what? After P wave is most important part is PR interval. I think a lot of people they are asking something. Those who find axis confusing can go to the Google and can see that, but I'll send the axis diagram also. Axis is nothing, it's an electrical axis. There is no axis as such done. So PR interval, this is very, very important. Why it is important? Try to understand. General PR 0.12 to 0.2, I told you that time, 3 to 5 small square. Okay, if the somebody asked no heart block, now learn, I'm not sure whether you are there or you left it, more than 0.2 second. Oh, there is some power problem, just a sec. Okay, if it is less than 0.2 second, it's the first degree heart block. If it is less than 0.12 second, okay, I was telling about P wave Qrs complex, right? I don't know what is the problem with this. P wave Qrs T complex, right? So what is happening is here P, then Q, R, S. So this is the what I was saying, the PR interval is something what I was talking. If it is more than less than 0.012 second, there is something called WPW syndrome, if you remember. Okay, if you don't remember also okay. Prolonged, if PR interval is more, that means what? Anybody? AV block, right? Atrioventricular block. If it is less 0.12, it is less, WP syndrome. Okay, if it is decreased, PR interval is decreased, much decreased, it can happen any inflammation also, like pericarditis. It doesn't allow to repolarize easily. That's it, nothing else. Don't make things complicated, it's very easy. Okay, next characteristic which is very, very important is of course the Q wave, but you know very well Q waves, so I will not go detail into the Q wave. What you have to see in the Q wave, if I told you the Q wave is generally 1 to 2, 1 is enough, maximum 0.04 second. So if it is more than 2 small square, that means 0.08 second, more than that, that means what? Old 0.08 second, I mean, sorry, more than 0.04 is normally the old inferior wall myocardial infarction. How it is there? Just try to correlate, you will find it. Okay, next is after Q, I will take it as a QRS complex. Very, very good to know that QRS complex we can learn little detail, little this one. So it is about, as I told you, 0.08 to 0.12 second. So 2 to 3 small square boxes, right? Small square. So what happened here? if there is a broad QRS, okay, 100% ventricular arrhythmia. Okay, now arrhythmia is of different type, like ectopic, tachycardia, fibrillation. That's a different story. So any pathology which disturb the bundle of His, okay, will create the bundle branch block. Okay, and this could be two types: right bundle branch block and left bundle branch block. Okay, how will you understand? I am giving you mnemonics. If it is a right bundle branch block, M, remember marrow. Okay, why you have to remember marrow, I'll tell you. Okay, V1 and V6. See your ECG on V1 and V6 in case of right bundle branch block. What will happen? You know, it will go like this: P wave, okay, P wave, then Q wave, then R wave like this, S T wave, finish. Okay, M at V1. So if you see your V1 lead, it will be M like this. And the same thing if you see your V2 lead, P wave, okay, it will go to the down W like this. Okay, so this is how marrow, right bundle branch block. But left, what about left? See left how it happens. Left, you remember the word called William. Okay, again WM. So V1, V6. So V1, if you see that time the ECG, it will be like a W, like this. Okay, and then V6, it will be like a M. So if you remember this much, V1 and V6, you know, marrow and William, right and left bundle branch block can be understood easily. It's very easy to understand. Very, very easy. I don't have a notes to give you. Okay, so I think another 7 to 8 minutes we'll finish the class. So now QT interval. Okay, I will go to the next slide to go better. Yeah. So QT interval. What do you see in QT interval? Nothing. You don't have to see much things here because there are a lot of things like you know, like generally QT interval is what? 0.36 to 0.044 second. Okay, QT is nothing. It is just P, Q, R, S, T. So P, Q, R, S, and T. So QT is like this. QT. So now if you calculate PR plus QT is equal to 1 cardiac cycle. Okay, simple, very simple. This you should remember because many of the exams they ask you the question like this. Okay, so if the duration is more than this, nothing, hypokalemia. Teacher, I know if I start teaching you another 3 hours, it will go. Okay, hypokalemia, it can happen. If this is less than 0.36, then what can happen? There is a syndrome, I think you would have understood. There is a syndrome called ventricular arrhythmia. I mean, what kind of that? Torsade de Pointes. There is a disease, Torsade de Pointes, kind of ventricular arrhythmia that can happen. Okay, now ST segment. What are you going to see again? ST segment, abnormality I'm talking about. ST segment, lot of abnormality. Okay, most important is acute myocardial infarction or pericarditis. You are going to see this. Okay, how? V1 and V2, V3, V4, V5, V6. Just see that, nothing else. What you are going to see? ST elevation, I told you, ST elevation is something very, very important feature for everybody. And in acute MI, it happens. There are 4 stages. I don't want to get into that. ST elevation, if it happens, you know, like acute MI, it will be for 1 hour it will come. And then another 2 to 3 hours, it will come ST elevation. Then it will come the T inversion. Then it will come the Q wave, a different kind of Q wave. Okay, 1 to 2 days. So acute MI, no problem. At least you remember V1 and V2 for septal wall MI, and V3 and V4 for if it is a damaged graph means anterior wall MI wherever you kept it, and then this is for the lateral wall MI, V3, V5 and V6. Now if ST segment is, I'm talking about this is elevation. Okay, elevation should not be normal, these like this kind of thing. Okay, now depression is normally nothing, myocardial ischemia. If blood is not supplied properly for a very long time, ST segment will get depressed. I'm telling you, depressed means nothing. From the isoelectric line, it will show the downward trend. Got it? So that is something very, very important. Because of scarcity of time, I will not let you to go very detail about it. Now the last is T wave. What do you see in the T wave? What do you see in the T wave? Either you will see the normal upright thing. Okay. T wave, as I told you, always up, right, except in AVR and V1 lead. It's always upright, right? So what happened normally? Okay. Hyperkalemia, you would have heard hyperkalemia, more potassium. In that case, what happened? Peaked T wave. Why? Because repolarization, more potassium, right? So PR in that case, not only T wave will confirm, even the PR intervals should longer and other stories there. I don't want to get into that. Now, hyperacute T waves. It happens. T wave goes like this also. In that case, we say hyperacute T waves. What is hyperacute T wave says? Early STEMI. Now don't ask me STEMI because every one of you know ST, elevated myocardial infarction. Okay, hyperacute T waves in that. Now if T wave is getting inverted, then again it is a myocardial ischemia or ventricular hypertrophy. Why? Anybody can tell me ventricular hypertrophy, why it is very important for physiotherapist? Okay, if it is more hypertrophy, repolarization will take that much time. Number one. Number two, more repolarization, the waves will, resultant vectors will work in such a way that it will show the resultant vector will show the inversion of T wave. Okay, so this is only thing you remember. Now for physio, one more thing is important that will take 30 seconds to, that will take about 30 seconds to do. Okay, just 30 seconds to do that particular part. I'm not seeing questions or any comment right now in the chat box because I want to finish the last part, which will take just 30 seconds, and I will complete the 3 hours class. Okay, for physios, you have met your patient where you have a left ventricular hypertrophy. How do you understand the left ventricular hypertrophy? Nothing. Just try to say, check deepest S wave. Why deepest S wave? Because of the after the repolarization part, right? S wave. Remember that S wave, PQR S wave. Okay, deepest S wave, especially in the V1 and V2, these two leads. Now, tallest R wave, tallest R wave, more than 35 mm. That is not correct. Okay, especially in the V5 and V6, it should not cross normally 27 mm. I have seen, but 35 mm if it is crossing, I'm telling you it is 100% left ventricular hypertrophy. You don't need other test normally. Right ventricular hypertrophy. Okay, now let us talk about right ventricular hypertrophy. Normally right atrial, or what we say, right axis deviation you will find on the graph. If you are not able to understand, at least R by S amplitude, if you see, if it is more than 1 in V1, V1 is a very important thing. Okay, V1 leads. So if it is more than 1 and if it is less than 1 in V5 and V6, I'm telling you it is 100% R right ventricular hypertrophy. Though there are other factors also, like R wave should cross in V1 should be about like 7 mm or something, but these two factors are very important. So LVH and RVH is very, very important concept for physical therapists. So with this, I finished my most of the part today's And actually, I apologize to everybody that I took half an hour extra. That was mainly because in earlier part of class, you were like bit slow to go with. In fact, I went slow, so it took half an hour extra. Sorry if you have got held up with any other things or something. So I'll stop sharing. Uh, Now I will talk about certificate part will come. You have to just send the code message to number 9066990059. The code is coming now. Thank you for your wonderful feedback that you are saying it's a nice presentation. Probably next time when we meet up and when we do our presentation, we'll do it a bit faster. Okay. Yeah. So I don't know, ECG is coming another 2 months in hand, but still, I don't have notes on that, but still I'll try. Whatever I told you, I have, oh, I don't have as such notes, but yeah, that's my personal, I can tell you the graphic notes I always keep. Reference, of course, you can refer always the good websites. If you want to learn, you can refer good books. You can refer, in fact, Guyton for your basic knowledge as well as how it is. And then you can refer internal medicine by Davidson. Those like have like how sinus arrhythmia looks and how atrial filtration looks. So today I could not get those ECG, and then it was getting delayed also. Sometimes later I'll definitely send you those things, or maybe I will do once again the ECG class. That time you can join, you can see that different kind of ECG, and you can find out the the thing is like how you can find out these things. So but still I have told you earlier that please bring your paper and pen and sit with me. It will work a lot. If you have paper and pen, many of things you will note it down. So tomorrow when you talk, when you go through particular uh, like what we say, particular text literature, especially from the Davidson and everything, there you will be able to correlate my lecture. And I know I have made things easier, no doubt. Though it's ECG is a big topic, I told you earlier, it doesn't take less than 3 to 4 hours in general. I went a bit slow, otherwise could have. So see you, sir. You can share the code. Dr. Divakar?
Yes, sir, it's already displayed.
Oh, acha, acha. Fine.
So you can see the chat box, any queries.
Atrium repolarization. Well, atrium repolarization, I'll send you that in the group, no problem. That's very rare, very, very rare. In fact, I would have also seen once or twice. So code is not coming, sir. I believe few people they are asking. Yeah, how can you explain about 300 by PR? I did not tell PR interval. Again, correct yourself. I said 300 divided by number of large boxes between 2R. Okay. Now, that is the rule that goes for the normal ECG. When it is a abnormal or irregular ECG, there the rule changes. There you have to multiply the 10 with number of R waves in 6-second ECG. So you have a mark on 6-second ECG. You have to see how you can do that. Okay, RVS, right ventricular hypertrophy, very simple. Right ventricular hypertrophy. There, as I told you that time, if you remember, right ventricular hypertrophy is like how you have to see on the ECG. There are some features like normal, what we say, you have to see the, of course, you have to see the R waves. You have to see your normal, what we say, S waves, and you have to divide the amplitude of R wave to S wave, especially in the V1 lead. If it is coming more than 1, then you have to go to the V5 and V6 lead. It should come less than 1. Then you can confirm it is a RVH, right ventricular hypertrophy. Okay. Well, 7 mm if it is more, as I told you, R wave also it's possible. Some of the numbers they are showing that it has been blocked or something. I'll tell you that our system is a bit automated. If I'll speak to the help, like technical help side. The thing is like if you ask the certificate before the event finish, that's what it was found. Because I can tell you that we at My Rehab Academy bring our instructor from a lot of research, and then we have found many of the candidates asking even personally to my number that like please provide the link of the certificate even before the event. So that was a bit disappointing to us because see, we have given free membership to many of you. Not just a matter of being free, it's a matter of learning. So I asked you, like, look, certificates will definitely come. If it is not coming by automated system, our tech will help you. But we cannot give certificate those who have not joined. And before joining, if you ask, that too through the message, even last time it happened with my thing, because every week almost I conduct myself like cardiopulmonary subject. Any of the topic I keep uh, talking. So like mostly it is free. So what happened? Like somebody asked me, sir, can I get the link of certificate now only? So it was disappointing. I didn't tell anything. So mostly because of that, it can happen. The automated system can, or maybe some reason. I'll just find out from the back end what it is, and I'll inform CEO sir also. Is there anything which he can help us? We'll do that. But try to learn as much as possible because here at My Rehab Academy, you are for learning. Angle and all you don't have to decide for according to the patient. You have to keep in the mind 3 bipolar, 3 unipolar, and 6 leads of chest. That's it. Thank you, Mohammed Jan. You enjoyed, and thank you everybody who told like it's a good session. ECG MRA is a code for the certificate. I think it's getting displayed. Code will be valid for another few minutes, I believe. Maybe another 20 minutes it is valid, I think. 20 to 30 minutes. Thank you, Manisha. It was informative. Thank you. You found informative. Thank you, Dr. Banasali. Thank you, Senthil sir. A link will come to you once you message to the 9066990059. Link will be sent to you. Thank you, Dr. Palanisamy. Okay, well, U wave today. Let us not talk about U wave because it will take much time. U wave, it comes. It's a kind of little tragic type of thing. It's no problem if somebody discourage also, no issues at all. Discourage gives us always courage to work better. Yeah, I'm really a hardworking person. I'm not very intelligent. Thank you. Thank you for your feedback. Thank you, Sri Ramji. Thank you, Dr. Aarti. See you, sir.
Yes, sir.
Yeah.
Can we?
Yes. That's what I was saying. Like
Thanks a lot, Dr. Saurav. Thanks.
Yeah, and a few people they have not got the link, so like another half an hour that code will be valid. So maybe no, the link will open. Dr. Pooja, link will open. There are a lot of traffic. Just wait for some time. It will open.
Yeah.
Thank you, Dr. Sudha.
Thank
you. Thank you, CEO sir. Thank you all the participants. Thank you, Dr. Divakar.
you.
Thank you, sir.